We start with the first session with Weedon skin pathology, and for the next few weeks, we will be talking about different reaction pattern in the skin, and it will be like very introductory type of session. However, we'll try to cover the most important aspects of each pattern. So, what I thought to do in these sessions, because the majority of people feel intimidated with those like different reactive patterns, I thought as you are starting to learn about these patterns, if I talk about like a different aspects of all these patterns, it will get confused for somebody who is starting new or for somebody who is not so doesn't have a solid knowledge about these topics. So we will try to learn like specific shapes for each pattern and master those shapes. And as you master those shapes, you will be able to mix those patterns together. Because remember, we are just studying a specific pattern at this specific time. But in real life, you may see like different patterns together, and you may encounter like overlap between two or three different patterns. So keep in mind that these sessions we will just focus on specific knowledge that is related to this specific example. So I know like many people use different topics to different like approach to this specific topic. So what we like or what I like to think about like the different patterns, they are organized anatomically from top to bottom, from epidermis to junction to dermis. So in the epidermis, we like to think about two patterns, the spongiotic and the psoriasiform. In the junction, in the epidermal dermal junction, we like to think about two patterns, the lichenoid, the vesiculobullous, and for the dermal, we like to think about granulomatous and vasculopathic. So when we say spongiotic, we mean intraepidermal and intercellular edema. When we say psoriasiform, we mean regular epidermal hyperplasia. When we say lichenoid, we mean basal cell damage and interface dermatitis. When we say vasculobullous, we mean blistering within or underneath the epidermis. When we say granulomatous, we mean granuloma, chronic granulomatous inflammation in the dermis. When we say vasculopathic, we mean the pathology is in the vessel. So spongiotic reaction, if you look into the chapter, it has a lot of diseases. So it is intimidating to think about like all these diseases that you have to learn in 20 or 25 minutes. Instead, I would give you in this 20 to 25 minutes a just like an overview or base knowledge that helps you to differentiate those different entities based on specific features, and that way you will be able at least to have a starting point, and then if you need to divide like subcategories, it will be easier to approach it that way. So first we have to recognize the spongiosis, and we will talk about this in a little bit. After we recognize the spongiosis, I want you to think that the spongiosis is happening in reaction to something. Spongiosis doesn't happen by itself. There is something happening or introduced to the epidermis or the dermis that cause that spongiosis. And then after we figure out that specific reaction from the history or from the clinical picture, I want you to look into the special cell type, meaning is there neutrophils, is there eosinophils, is there lymphocytes, or is there a specific feature that is unique to that specific pattern. So after we recognize the pattern that it is spongiosis, and we thought about the etiology, then we think about the type of cells. So we'll talk about all these different diseases in kind of like an order, but spongiotic reaction are divided into neutrophilic, where the main cell type is the neutrophils, eosinophilic, where the main cell type is the eosinophil, Miliaria, where the problem is in the sweat gland or sweat duct unit, Follicular, where the problem is in the hair follicle, Pityriasiform, or a scaling type of lesion. So when you hear the word Pityriasiform, I want you to think about scaling disease. The other spongiotic disorders, this is like a wastebasket we use when we encounter a diagnosis that cannot be fitted into this specific category. So spongiosis, what is spongiosis? This is cartoon to show you the difference between the normal skin and the spongiotic skin. So spongiosis is basically there is a fluid in between the keratinocyte and the epidermis. And in comparison to the nice hexagonal keratinocyte shape, you will see the shape of the keratinocyte becoming a little bit elongated, and they have pointy edge because the fluid is pushing away the cells from each other, so they are separated. If the spongiosis is severe enough, you start seeing blister and vesicles, as we see in this example. The etiology for spongiosis is not well understood. Some think it is hydrostatic pressure that pushes the fluid from the dermis into the epidermis, or it is an onco or osmotic gradient that is pulling the fluid from the dermis into the epidermis. The end result is we have fluid inside the epidermis is separating the keratinocyte from each other, and if it is severe enough, you start seeing blisters and vesicles. With this reaction, you start seeing also the acceleration of the keratinocyte in moving upward, and as an end result, we see the parakeratosis. So, as an introduction, what I will try to do is to present a normal skin picture on the left side and disease picture on the right side, just for comparison. And you can pause this video and try to come up with the diagnosis, or at least if you don't know the diagnosis, you can just try to describe or try to identify what is the difference between the normal skin and the abnormal skin in this category. Remember, we are talking about spongiosis, so spongiotic reaction will be the main theme for all these diseases. And we may see if the spongiosis is severe enough, we may see the vesicle formation or the blister formation. And the other thing I want you to think about when you are approaching those lesions, what is the specific cell type that we see? Is there any neutrophils? Is there eosinophils? Is there something else feature that is unique for this disease? So in this disease, we see the vesicles that are filled with lymphocyte and neutrophils. We also see that the epidermis is hyperplastic. We see there is an edema in the papillary dermis, and there is perivascular interstitial infiltrate. So this is specific diagnosis of prurigo pigmentosa because the clinical picture is unique with eruption of urticarial papules distributed symmetrically in a wedge shape on the back. This is part of the neutrophilic spongiosis, and if you look into the list, it has a lot of diseases. We will not be able to cover all of them, but I tried to group them into three groups. The first group, always think of infection, whether it is staph, Neisseria, dermatophytes, or bites, or scabies. So all these are related to infectious etiology. Also think of autoimmune problems. Could be related to neutrophilic spongiosis, or the waste basket, that if we cannot fit into the infectious or the autoimmune, we think of hereditary, we think of, for example, glycogonoma syndrome, or pustular contact dermatitis, erosive pustular dermatosis of the legs. So different entities that don't fit into these categories. Another entity I want you to think of is in the autoimmune etiology is IgA pemphigus for the neutrophilic spongiosis. In IgA pemphigus, we will see the pustules is subcornea, meaning underneath the corneal layer, and with acanthosis. So if we thought about this entity, you can ask for DIF, or direct immunofluorescein, where you see the IgA is intercellular, meaning in between the cells of the epidermis. Another entity also is very commonly tested on the exams, acute generalized xanthomatous pustulosis. And here we have a drug in the clinical history, most commonly antibiotic, where we see also neutrophilic spongiosis, but notice here the pustules is subepidermal compared to the subcorneal pustules in the IgA pemphigus. Moving on to a second category, and here we have the normal skin, and here we have the disease skin. So you can pause the video and try to describe what is the difference between these two entities. So we see here there are vesicles in the epidermis. We call them intraepidermal vesicles. We also notice the superficial dermal edema and the perivascular lymphocytic, and most importantly, eosinophilic infiltrate. So if you go on high power in these lesions, you start seeing a lot of eos. This is a classic example of allergic contact dermatitis, and part of the eosinophilic spongiosis, we have a long list of diseases that most of the time a dermatopathologist will feel more comfortable to include differential diagnosis if the clinical history is not suggestive. I found this mnemonic online, which will be probably helpful to some of you to remember the eosinophilic spongiosis, IHAPID, insect bite, herpes, allergic contact dermatitis, pemphigus and pemphigoid, incontinentia pigmenti, ETN or erythema toxicum neotorium, and drug reaction. We have a specific disease, Still's disease. Still's disease appears as erythematous scaly papules and plaques. And on histology, in addition to the spongiosis, the eosinophils, perivascular inflammation, we have dyskeratotic keratinocytes in the upper epidermis. Another specific disease is Wells syndrome. Here, in addition to the spongiosis, we have a very specific histology is this sign, we call it the flame figure. As you see, like here, the blue and the pink, it looks like a flame. And this happens in the collagen because of the degeneration in the collagen due to the degranulation of the eosinophils. Clinically, it appears as annular erythema to villous plaques without epidermal involvement. Moving on to the heat rash or miliaria. So miliaria is a group of disease that affect the sweat duct or the sweat unit, and usually are divided, those groups depends on the location of the obstruction. And I want you to think of the mechanism because this is a duct. So if the obstruction happens in the surface, most commonly we see the effect in the surface. But if the obstruction happens kind of deeper along the duct, the effect will be deeper. So it's a location specific diagnosis. So those categories, we have the obstruction. If the obstruction happens in the stratum corneum or the superficial layer, we have Miliaria crystallina. If it happens inside the epidermis, we call it Miliaria rubra. If it happens in the dermal epidermal junction, we call it Miliaria profunda. These are just two examples to show you the difference between the superficial and deep units of the damage. Here the damage is in the sweat duct, and here the damage also in the sweat duct. So if you see these areas, the vesicle formation will be in the top epidermis. If you do PASD staining, this area will stain very pink because of the EPS, or the extracellular polysaccharide substance, and usually it's subcorneal pustule filled with neutrophils. If you look also into the dermis, you will see with the lymphocyte also neutrophils. So this is Miliaria crystallina. Compared to this example where we see the damage is kind of deeper into the dermis or into the sweat unit, along with the spongiosis and the lymphocyte infiltration, this is Miliaria rubra. Again, this is another classification compared to the normal skin. We can see here is the hair follicle is the only affected pathology in this entire skin, along with the hyperkeratosis, some parakeratosis. We have also the spongiosis is restricted to the follicular unit, along with the perivascular inflammation. So this is infundibular folliculitis, usually is common in African American individuals, appears as pruritic papular eruption on the trunk and proximal extremities. Follicular spongiosis contains 4 groups: infundibular folliculitis, as we saw in the previous example, atopic dermatitis if it affects the follicular unit, epocrine miliaria, and usually this is limited to the axilla and usually presents with rupture of infundibular follicular portion of the epocrine duct. And we have also follicular or eosinophilic folliculitis. Basically, we have the main cell type is eosinophils. And I will show you example on this specific entity when we do the slide session. Moving on, here compared to the normal skin, we have the pathology is kind of limited to a specific area, along with the hyperkeratosis and some inflammation in the dermis. So we have hyperkeratosis, parakeratosis, absence of a granular cell layer underneath the hyperkeratosis and parakeratosis. In addition to spongiosis, we have also acanthosis as part of the spongiosis and the hyperplastic epidermis, perivascular lymphohistiocytic infiltrate, and we have eos and erythrocyte scattered in this area that is moving or creeping from the dermis to the epidermis. So this is an example of PR, Pityriasis rosea, and usually a very characteristic clinically, where we see the Harald patch, ovale salmon pink papulosquamous lesions on the trunk, neck, and proximal extremities. We have the famous Christmas tree, where we see the lesions follow the skin cleavage if you read the literature, there are debate about like whether this disease is viral or not. Pityriasiform spongiosis has different lesions, PR, triasiform drug reaction. If the drug is suspected, usually you don't see Harrell patch, usually more oral lesions, and the edema is subepidermal. Erythema annulare centrifugum I will talk about, but before we talk about the specific entity, I want you always to remember that when you see the vesicle or the blister formation in Pityriasiform spongiosis, always look inside. You will see lymphocyte and histiocyte and Langerhans cells, and after that you can make the different specific diagnosis. When you think of Pityriasiform, check the clinical history because usually these lesions are scaly lesion, and in the clinical history, the clinician will mention that there is a scaly lesions on the body. So erythema annulare centrifugum or EAC has a specific clinical feature that has something called the trailing scale, where you see this erythematous scaly border around the lesion. If you biopsy that area, you will see something very specific that the perivascular inflammation has a coat sleeve appearance like this, very specific to this specific entity. Lichen striatus also has a specific clinical presentation where you see the lesions, the scaly lesion, are linear. And on histology, you will see all these pigmented melanophages in the superficial dermis along with the apoptotic keratinocytes in the epidermis. Finally, the other spongiotic disorders, which are like a wastebasket, we put all the different diseases in this category when we don't have a specific diagnosis. And if you read Weedon, he clearly mentions that it is difficult to make specific histopathologic diagnosis of some of the disease in this category, and often you sign out these cases as spongiotic dermatitis consistent with, and you mention list of differential diagnosis. So I will try to cover some of the specific entities that we encounter in real practice and also commonly tested. So when you see superficial ballooning, necrosis, and neutrophils, always think of irritant contact dermatitis. If you see vesiculation that is organized in vertical order, along with psoriasiform hyperplasia, depends on the chronicity of the lesion. With eos and edema and superficial in the superficial dermis, always think of allergic contact dermatitis. Nummular dermatitis is usually grouped with the allergic contact dermatitis, but usually the picture is more chaotic and you see more neutrophils in these lesions. If you see parakeratosis, extravasated RBC, and lymphocytes, always think of PR. When you see mild spongiosis, proliferation of the superficial vessels in the dermis, and extravasated RBC and hemosiderin, always think of stasis dermatitis. This is just a picture to show you the superficial ballooning in this area. So this is an example of irritant contact dermatitis. In this example, we see the psoriasiform hyperplasia, along with, if you go on high power, you will see the eos and the edema. So this is an example of allergic contact dermatitis. This is a nice example of PR I presented earlier. And here we see the edema, the spongiosis, the proliferative vessels, and the extravasated RBC and the stasis dermatitis, especially if this is on lower extremity, is very characteristic for stasis dermatitis. Seborrheic dermatitis also has a specific feature. Depends on what time of the lesion you biopsy. So if you biopsy in the acute stage, you will see psoriasiform hyperplasia of the epidermis along with focal parakeratosis. When you biopsy in the subacute phase, you start seeing the widespread spongiosis. When you biopsy in the chronic stage, you see the psoriasiform spongiotic changes with neutrophils and exocytosis. This is a clinical picture where you see the erythematous scaling papules and plaques, and sometimes with greasy yellow appearance in the head and neck, which basically seborrheic areas. If you see isolated lesion in the skin with unilocular vesicle formation in the epidermis, however, in around that isolated lesion, the epidermis appear normal or not spongiotic. Along with thick stratum corneum, think of Pemphilex. Pemphilex is usually found in acral skin. It used to be called dyshydrotic eczema, but Weedon discouraged using this terminology because the literature has found that has nothing to do with sweat problems. Usually appears as itchy vesicular eruption of acral skin, commonly in female, and resolve within a few weeks, leaving a localized area of desquamation. If you happen to think about this diagnosis, you have to always do PAS staining to rule out dermatophytes because they present similarly in the clinical picture. So this is the end of the chapter. We'll move on to the slide session.